Assalamu alaikum, everyone. I welcome you all to our today's session on antenatal care. I hope I will be of some help to all of you. I'm Dr. Shakeela Younus. I passed my MBBS from Dow Medical College, Karachi, Pakistan. Then I have passed my membership and fellowship exams from Pakistan. I did my MRCOG from UK and MRCPI from Ireland. Let's start with our topic now. Every year, there is estimated 200 million pregnancies in the world. Many of these pregnancies are at risk of an adverse outcome for women and their infant. Risk cannot be totally eliminated, but it can be reduced through effective, affordable, and acceptable antenatal care system. To be most effective antenatal care, it should begin early in pregnancy and continued at regular interval. These are the references I have gone through. Antenatal care NICE guideline published in 2021, and some basics from 10 teachers, obstetrics, and Oxford Handbook of Obstetric and Gynecology, air travel from Scientific Impact paper published in 2013, and Vaccination in Pregnancy and Exercise in Pregnancy dog articles. Aim of antenatal care is assessment and management of maternal risk and symptoms and assessment of fetal risks. Prenatal diagnosis and management of fetal abnormality. Diagnosis and management of perinatal complications. Decision regarding timing and mode of delivery. And parental education regarding pregnancy and childbirth and child rearing. At booking visit, in first trimester, usually it should be before 12 weeks early in pregnancy. And some women may present late in second trimester. Comprehensive history should be elicited to rule out any medical or any high risk factors. And a full physical examination should be performed. In history, antenatal file should be made with the personal data, including name, age, occupation, and duration of marriage, religion, nationality, and current pregnancy, if it was a planned or unplanned pregnancy, spontaneous or IVF. Presenting complaints, if any, and to establish expected date of delivery, ask for last menstrual period, and regularity of cycle and contraception methods, if ever she used, and any pap smears before done and their reports. Obstetric history in multigravida, it's very important. Parity, miscarriages, and previous living children's, and weight of infant, any complication during delivery, operated. If it is what was an operative delivery, then indication and type of anesthesia was used. Maternal and fetal complications in any of previous pregnancies. They will be helpful in planning future plan for delivery. Medical history to establish if she has any chronic medical conditions, and surgical history of abdominopelvic surgeries and accidents involving injury of any bony pelvis, and any genital repairs or cervical cerclage in previous pregnancies. Allergies to food and drugs. And medications, if she is taking any, then they should be documented and assess their safety during pregnancy. Family history may reveal some information about genetic diseases running in the family, and other medical disorders like diabetes, hypertension, heart disease, and hemolytic anemias. It is important to identify the risk of postnatal depression. It's very important to assess ask the history of previous personal or family history of psychiatric disorders. Any social problems, including domestic violence and previous self-harm. Full physical examination should be performed at first contact, height and weight assessed to assess BMI. Vitals and check for anemia, assess edema and cardiovascular status, and lower limb examination, abdominal examination, and breast examinations. If she is late in pregnancy, then fundal height after 25 weeks, lie and presentation in third trimester, and fetal heart auscultations, and if presence of any scar on abdomen. At booking visit, it's important to advise and support women on healthy lifestyle, including diet, exercise, smoking, alcohol, and antenatal visits, how many she will come, and what is the purpose of antenatal visit, and screening test. First, contact with healthcare professional. Ensure the woman is given information on folic acid supplementation and their importance, lifestyle advice, again, antenatal screening and booking appointments, how many times she will come in. Here, I will give you some a breakthrough booking appointment. Calculate the BMI, measure blood pressure, dipstick urine test for protein, glucose, and blood, and ultrasound for gestational age, nuchal translucency if it is 11 to 13 plus 6 weeks, cross structural abnormalities if she is late in pregnancy, like 19 to 20, 18 to 20 weeks. Blood test for hemoglobinopathies, rubella, VDRL, HIV, hepatitis B virus, red cell allo antibodies, and CBC for anemia. So we'll discuss it all in detail, one by one. Give her information on antenatal classes if available at your setup, if any, pregnancy care pathway, how the baby will develop, and nutrition and diet and vitamin supplements. According to NICE guideline, for primigravidas, 10 visits, and for multigravidas, 8 antenatal visits. We will discuss one by one. Modeled by WHO, they have a one focused antenatal care model that's 4 visits in first trimester 8 to 12 weeks, second trimester 24 to 26 weeks, third trimester 2 visits at 32 and 36 to 38 weeks. Then she will come at 41 weeks if she has not delivered yet. Other model is 2016 WHO model, where there are 8 visits, 1 visit in first trimester and 2 visits in second, and 4 visits in third trimester, 5 visits in third trimester. If she has not delivered by 41 weeks, she will come again. So in roughly, we can ask patient to visit monthly until 32 weeks. Visit every 2 weeks after that until 36 weeks, and visit weekly until delivery. Now, second trimester, each antenatal appointment, what is the purpose? At 16 weeks pregnancy, we'll discuss with her the screening results, what we have done in first trimester visit. We'll investigate if hemoglobin level was less than 11 grams and offer information and arrange anomaly scan at 18 to 20 weeks. At 25 weeks visit, it's only extra visit for primigravidas. We'll check blood pressure, urine, dipstick for, and plot her symphysio-fundal height from 25 weeks onward. 28 weeks visit, we will do a screening for anemia, atypical allo, red cell allo antibodies. If a patient is Rh negative, husband is Rh positive, then we can give her anti-D prophylaxis if she is not sensitized. Then again, blood pressure, urine dipstick, and plot her symphysio-fundal height monitoring. 31 weeks, again, it's for primigravidas on extra visit, blood pressure, proteinuria, and a check for symphysio-fundal height and fetal heart or auscultation. 34 weeks visit, here we'll discuss with her plan for labor and birth, and including pain relief and birth plan for her, and give anti-D if she is Rh negative and non-sensitized. Blood pressure, proteinuria, again will plot symphysio-fundal height. At 36 weeks visit, we'll discuss about the baby, breastfeeding, vitamin K prophylaxis, postnatal self-care, and awareness of any postnatal blues and postnatal depression. Blood pressure, proteinuria, and symphysofungal height, again the same. At 38 weeks, it's will again check her white blood pressure for proteinuria and then plot her symphysofungal height, now lie and presentation. At 40 weeks, again, blood pressure, proteinuria, and symphysofungal height, lie and fetal presentation and fetal hearts, and give information about prolonged pregnancy at 40 weeks. If she remains undelivered by 41 weeks, we'll offer her membrane sweeping. And if remain undelivered by 42 weeks, we'll admit her for induction of labor. Antenatal care routine blood test, what we'll perform on first trimester visit. Full blood count to rule out anemia, blood grouping antibody screen to rule out RHD. If she is RHD negative, then rhesus isoimmunization, and to detect abnormal antibodies such as CAL and DUF. Rubella screen, around 2% of nulliparous and 1% multiparous women, they are not immune to rubella. It is recommended that these women receive postpartum rubella vaccination. Syphilis screen incidence is low in UK, but still there are outbreaks do occur. So early treatment can prevent congenital syphilis in neonates. So screening and treatment is cost effective. Hepatitis B screen in all women in pregnancy at booking so that effective postnatal intervention can be offered. In adults, if they develop hepatitis B, virus cleared within 6 months in 90% of those who are infected. But in neonates, 90% become chronic carriers with risk of post-infective hepatic cirrhosis and hepatocellular carcinoma. That's why it's needed to screen and prevent earlier. Active immunization to neonate with hepatitis vaccine may be adequate to those where the mother, to those neonates where the mother was surface antigen positive only. But where the mother was core and E antigen positive, then passive and active immunization of hepatitis B should be done for all. HIV screen is recommended as universal screening for all women at booking visit, because vertical transmission from mother to fetus can be significantly reduced by 2/3 by treatment of mother with antiretroviral therapy during labor and infant for 6 weeks postnatal. It further reduced by cesarean section and avoiding breastfeeding. Specific blood test, if hemoglobin electrophoresis is not performed routinely, but in patients where or in specific ethnic areas where thalassemia and sickle cell anemia disease are more common, like Cyprus, Eastern Mediterranean, Indian subcontinent, Southeast Asia, thalassemia should be ruled out by hemoglobin electrophoresis in patients who are anemic, persistently anemic. In Afro-Caribbean, sickle cell disease or trait is common. If woman is affected, then partner testing is very important to assess and counsel the patient regarding prenatal genetic testing for the baby. Persistent anemia despite of treatment, undiagnosed cause, this is another indication for HB electrophoresis in any woman or regardless of racial origin. Different tests, they can be performed according to patient's health status. If she is having thyroid disease or past history of thyroid disease, then thyroid function test. And if patient is having diabetes, then HbA1c to check for the control. And in patients with chronic hypertension and renal complications, baseline urea and creatinine should be performed. Screening for gestational diabetes by glucose tolerance test, it should be done in patient with all risk factors like previous gestational diabetes, family history of diabetes, unexplained stillbirth, obese patient more than 30 BMI, polyhydramnios, glucosuria at more than one occasion, and large for gestational age fetus in current pregnancy. So 75 milligram glucose tolerance test should be performed 24 to 28 weeks of pregnancy. New onset of hypertension at 20 plus weeks of pregnancy without proteinuria is gestational hypertension. So in history risk factor, maternal risk factors, we can evaluate if patient is primigravida. It is her first conception with new partner, past or family history of gestational hypertension, diabetes, or chronic hypertension, or renal insufficiency. History of APLA, antiphospholipid antibody syndrome, extreme maternal age, very young, less than 18, or very older, more than 35 years of old mother. Fetal factors, IUGR, oligohydramnios, gestational trophoblastic disease, multiple gestation and fetal height drops. They are the risk factors for developing gestational hypertension. We'll check her blood pressure and urine protein each visit in high-risk cases. Pre-eclampsia is the same, high blood pressure after 20 weeks of pregnancy with proteinuria in Lipara, age more than 40 and older, family history of pre-eclampsia, BMI of more than 35, multiple pregnancy, pre-existing vascular disease, for example, hypertension and diabetes. Each visit, blood pressure is measured and pregnancy, plus urine sample should be tested at the same time for proteinuria. But if once the preeclampsia is diagnosed, then proteinuria testing should be deferred. If we'll refer the patient to obstetrician, if a woman develop high blood pressure, gestational hypertension, more than 140/90 millimeters of mercury or higher within 24 hours. Or she needs urgent referral or admission if it is severe hypertension, like blood pressure of 160/110 or higher. She should see secondary care within 24 hours as urgent referral. Venous thromboembolism should be assessed at first contact. There is a flow chart in venous thromboembolism guideline. We should ask the patient all the questionnaire at antenatal booking appointment, and then at the time of each admission, and any significant event happened during pregnancy, like surgeries or anything. So she should be reassessed again for risk of venous thromboembolism. If high risk for DVT, then should referral to obstetrician or a referral to the concerned doctor should be made. Now, chromosomal abnormalities, another screening in the baby. Ideally, screening should be offered to all women at the time of booking. First trimester, if she's present, 11 to 13 plus 6 weeks, we can offer her combined test. Down syndrome, aneuploidy, or chromosome 21, 18, and 13 are the most common chromosomal abnormalities seen in first trimester. Can be evaluated in first trimester. Nickel translucency scan and blood test, PAPA and beta HCG. It has detection rate of 75% with false positive rate of no more than 3%. So this means that risk of 1 in 150 or less is considered as high risk and will proceed for diagnostic testing like in CVS or chorionic villus sampling. Advantages, 90% detection rate, but still it's a screening test. Patient should be always informed that it is a screening test. We need to do diagnostic testing after once it's high risk. It may detect abnormalities such as anencephaly and many of such structural defects like cardiac anomalies. And results usually available in first trimester, and surgical termination is possible in the countries where it is allowed. An acceptable detection rate for all trisomies. Disadvantages, expensive. It is expensive and needs expert to perform nickel translucency scan. Second trimester, if patient came late in second trimester, then still we can offer her triple and quadruplet test, where nickel translucency scan cannot be, it cannot be performed, but we can take dating scan and 4 blood test, estriol, HCG, alpha fetoprotein, and inhibin A. Risk of trisomy 1 can be calculated by multiplying the background maternal age risk, gestational age-related risk, and likelihood ratio of nickel translucency with 2 blood tests in combined testing. Nasal bone and tricuspid regurgitation are can be seen in Down syndrome cases at 11 to 13 plus 6 weeks scan. So then routine anomaly scan performed at 18 to 20 weeks. And if there is any abnormality or suspicion, then fetal cardiac scan and echocardiography can be offered at 23 to 24 weeks by fetal medicine unit. Third trimester, you will advise patient accordingly, but it is not recommended. Vaccination during pregnancy. Safe vaccination during pregnancy are hepatitis B if in high-risk patients who are negative, who are not vaccinated and they are very high risk, then we can give them hepatitis B vaccination during pregnancy. Influenza inactive vaccine can be given at more than 14 weeks, and tetanus and diphtheria if patient has not received her booster in last 10 years, or she has never been immunized, then she will be given tetanus and diphtheria combined vaccine during pregnancy. So they are, in TOG article, there are clinical classifications of vaccine according to their risks. Vaccine, they are contraindicated. All live attenuated vaccines are contraindicated, like BCG vaccine, measles, mumps, rubella, varicella, vaccinia, and HPV vaccine. They all are contraindicated during pregnancy. Vaccines specially indicated in pregnancy are tetanus toxoid, diphtheria toxoid, inactive polio vaccine, inactive influenza vaccine, pertussis vaccine. Vaccines, they are recommended in women in certain situations, like she is traveling to endemic areas, hepatitis B, A vaccine, meningococcal vaccine, pneumococcal, rabies, and typhoid and yellow fever vaccine. Make sure that she is taking nutritional supplements, folic acid 400 microgram per day supplementation in 3 months before and until 12 weeks during pregnancy. It reduces the risk of baby having neural tube defects and encephaly and spina bifida. Higher doses of folic acid supplementation, like 5 milligram, should be given in obese patient where BMI is more than 30, previous history of neural tube defects, and patient had bariatric surgery like gastric sleeve or gastric bypass. Vitamin B supplements are important from first trimester onward. Iron supplements and vitamin A supplementation intake should not be more than 700 microgram. It is teratogenic. It should be avoided, and patient should be advised to avoid liver in her diet. Then discuss about her nutrition. Daily requirement in pregnancy is about 2,500 calories. She should divide it in different portions. Bread, cereal, rice, pasta, 6 to 11 portions per day. 3 to 4 portions of fruit, 3 to 4 portions of protein per day, 4 portions of dairy, eggs and milk, and vegetables, 3 to 4 portions per day. She should reduce fat, sugar, oils. She should take it occasionally only. Now, simple symptoms of during pregnancy, nausea and vomiting, they are usually due to hormonal influences and emotional factors like stress, and they can be managed as by home remedies, adequate rest, relaxation, eating small meals, 6 meals rather than having 3 large meals, carbohydrate snacks at bedtime to prevent hypoglycemia, and solid food tolerated better than liquid food, so crackers and piece of dry toast. She can have food, should not have a strong odor, and it should not be very hot or very cold, and fried or greasy food she should avoid. Green ginger tea, and if there is no response, then medication, antiemetics can be prescribed. Heartburns, again, hormonal effect. It relaxes the cardiac sphincter of stomach and allows reflux and bubbling back of gastric contents. In third trimester, late in pregnancy, pressure of growing uterus on the stomach. These all are the risk. Home remedies, we can advise her to avoid lying flat, sleeping with more pillows and on her right side, and small frequent meals, antacid, avoid fried spicy food, and avoid citrus juices. Backache, again, maybe due to muscular fatigue and strain due to poor body balance, and there is increased lordosis during pregnancy in an effort to balance the body. So pregnancy hormones may often soften the ligament that some degree may cause this backache. So patient should advise to have exercise, stretching, and sit with knees slightly higher than hips. And patient should be reassured that lordosis will return after the delivery, and the strength of ligament will be returned after the delivery. Urinary frequency occurs due to pressure of growing uterus on bladder. The problem will resolve when uterus rises above in the abdomen after 12 weeks. Sometime it stays in second and third trimester, so Kegel exercises are recommended to help to maintain the bladder. If persisting and associated with the burning and urgency, then a test should be performed to rule out infection. Varicose veins, again, progesterone relaxes the smooth muscles of veins and result in sluggish circulation and pooling of blood, and pressure of growing uterus, again, it partially compresses the pelvic veins, hold the veins returning blood from the legs. So lying flat, how to manage it? Lying flat on bed with elevated feet and moving legs rather than standing still, compression stockings. And if a patient is having severe with pain and swelling, then referral to vascular surgeon is needed. Constipation, again, hormonal effect can cause reduced intestinal motility, and iron supplementation may have the same effect. So food modification is an important aspect. Patients should be advised to have high fiber diet, brown bread, green fruit and green vegetables that contains high fiber, and drinking a lot of water, walking, exercise, and laxative only prescribed by physician. Sleep positions, avoid sleeping on their back after 28 weeks of pregnancy, and to consider using pillows. Explain the woman that there is some link between going to sleep on her back and stillbirth after 28 weeks of pregnancy. Symptomatic vaginal discharge. Transparent vaginal discharge is common during pregnancy, but if it is associated with itching, soreness, smell, then infection should be ruled out by high vaginal swab culture. If there is high suspicion of sexually transmitted infection, then a specified test should be performed. Offer vaginal imidazole, clotrimazole, econazole to treat vaginal candidiasis, and consider oral or vaginal antibiotics to treat vaginal bacterial vaginosis. Sexual activity is completely safe with moderations unless patient develop bleeding or membrane rupture. Avoid if there is bleeding and low-lying placenta. Avoid in early pregnancy where there is history of previous recurrent preterm births and recurrent miscarriages or cervical circumference. Smoking in pregnancy may cause low birth weight and preterm birth. So offer her stop smoking services with nicotine replacement therapy if she agrees. And alcohol consumption again may cause miscarriages in early pregnancy. Avoid binge drinking more than 7.5 UK units, can harm the fetus. Exercise in pregnancy, daily 30 minutes exercise. It's recommended by ACOG and NICE, both guidelines. Moderate exercises per day. Woman who is already exercising, she can continue 30 minutes exercise per day. But a woman who is not exercising before getting pregnant, she can start with 15 minutes a day and then gradually increase to 30 minutes a day. What type of exercise is during pregnancy? Swimming, brisk walking, and strength conditioning, like stretching exercises, effective and beneficial. Sports like may cause abdominal trauma, falls, and excessive joint stress, scuba diving, they all should be avoided. Postpartum, mild exercise, immediate postpartum, with walking, pelvic floor exercise, and stretching. But high impact or heavy exercise can be delayed until 6 to 8 weeks in case of more complicated deliveries. There are contraindications to aerobic exercises. Absolute contraindications are hemodynamically significant heart disease, incompetent cervix or cervical circlage, multiple gestation, if patient is having premature labor, and placenta previa after 26 weeks. And relative contraindications to aerobic exercise: severe anemia, extreme underweight, less than 12, extreme morbid obesity, poorly controlled diabetes, and intrauterine growth restriction in current pregnancy. So 150 minutes exercise a week is required, as we discussed, 30 minutes a day. Now, air travel. So these are the routine questions patient is asking. So I just included all these in antenatal care. Many airlines, they do not allow women to fly after 36 weeks, singleton pregnancy, low risk pregnancy, because there is high chance of delivery. And if there is significant risk factor like preterm labor, previous history of preterm labor, or in patient with multiple pregnancy, even in low risk, they are prohibited to fly after 32 weeks. Many airlines, they require letter from doctor confirming that there is no anticipated complication for flight after 28 weeks of pregnancy. So any woman who is traveling after 28 weeks, produce her letter or certificate. In long haul flight, more than 4 hours, particular concern is risk of deep venous thrombosis. So it's accepted that prolonged air travel results in a small increase in absolute incidence of venous thromboembolism of around 3-fold. But with each increasing 2 hours in flight time, there is 18% high risk of venous thromboembolism. So it's very high risk, and patient might have motion sickness. You can give her antiemetics for that. There are certain medical conditions to air travel, contraindications to travel in medical conditions, like severe anemia with hemoglobin less than 7.5, a recent hemorrhage, otitis media sinusitis, recent sickling crisis, serious cardiac and respiratory disease, recent gastrointestinal surgery because the line, including laparoscopic surgery, because the suture line, it can burst with gaseous expansion from pressure changes. Then a fracture where the cast is being placed, where significant leg swelling can occur during flight, particularly hazardous in first few days. What is the advice we can give to patient? It's prudent to avoid air travel after 37 weeks in low risk singleton and 32 weeks in uncomplicated multiple pregnancy. with regard to minimizing DVT, appropriate journal advice would be given. What is journal advice? We'll ask the patient to have aisle seat to facilitate ease of movement, regular walk around the cabin, or carry out seat exercises like dorsiflexion and dorsi extension, flexion and extension of her foot every 30 minutes on medium or long haul flight. Maintain a good fluid intake to minimize caffeine and alcohol intake to avoid dehydration, and specific individualized risk assessment for thrombosis in pregnant women who are flying, and TED stockings if needed, in case of long haul flight. Short haul flight, less than 4 hours, no specific measures are likely to be required. But medium to long haul flight lasting for more than 4 hours, patient advised to wear fitted graduated elastic compression TED stockings. Additional risk factors for thrombosis, such as previous DVT, symptomatic thrombophilia with history of DVT, heritable thrombophilia, medical problems such as nephrotic syndrome, morbid obesity. These patients should be given prophylactic low molecular weight heparin, prophylactic doses from the day of travel until a few days after. Seat belt should be used one up and one down the baby bump, not over the baby bump, not under, it should be under the baby bump. Patient presented in early pregnancy with unexplained vaginal bleeding after 13 weeks. This is usually a common presentation. Offer NTD if immunoglobulin to women who present with vaginal bleeding after 13 weeks of pregnancy, if they are rhesus negative at risk of isoimmunization. Referral to secondary care for a review. Assess whether to admit the patient or not, if there is a risk of placental abruption, whether there is a risk of preterm delivery, how much is the vaginal bleeding, and women's ability to attend secondary care in emergency. Offer to carry out placental localization for ultrasound if placental site is not known. So take-home message is early detection of high-risk pregnancies and early referral and treatment. It reduces maternal and perinatal mortality and morbidity rate, improves physical and mental health of mother and children, prepare woman and her family for the labor and delivery care of the baby. Thank you. So now we can take questions.
Thank you very much, Dr. Shakeela, for your lovely presentation. I understand it's not easy to summarize and to put the information and the journey of 9 months in 1 hour, but you make it very nice, and it was really a very informative information.